I'd just like to take this opportunity to welcome Ali. And thank Ali very much for coming to speak to us. So Ali lives here in Otago, Christchurch, and it's an absolute pleasure to have her come and I guess talk a little bit more about or help us understand more really some of the issues that are specifically related to men who experience disability, and so we're really grateful for her wisdom and thoughts. Ali is a lecturer, but actually no, you're more than that. What's your role title now, Ali?
No, it is that. It is a lecturer.
Lecturer with the School of Physiotherapy, University of Otago, based in Christchurch, and has moved into providing students with a lot of support as well with research projects, etc. But I will let Ali tell you a bit more about her work, and huge welcome to you from us at the Burwood Academy, Ali.
Cool. Kia ora, everyone. Thank you so much for the invite. It's quite exciting to be able to explore physical activity participation for men living with disability, and just I guess as I go through the presentation, you will discover that there's not a lot of literature around men with disability and physical activity. So I'm trying to change that along the way with some colleagues. So my presentation today is a lot from literature and a little bit from me and some of the research that I've been involved in. So I'm going to share my screen, so just bear with while I find my presentation. Okay, can you guys see my slides? Excellent. I'm just going to pop you all to one side. Okay, so let's talk about, so I thought I'd just cover some men's health facts, talk about physical activity for men with and without disability, as I said, some barriers to physical activity. I'm going to talk a lot around masculinity, and that's an important concept for us to understand when we're talking about physical activity for men. We're going to chat through access to physical activity for men following stroke, which was my PhD studies, and some strategies to enhance men's physical activity. And then thinking about, and if we've got time at the end, maybe having a discussion around advocating for men's health policy. So in terms of men's health facts, why is men's health important? Well, we know that men die approximately 5.5 years earlier than women, and they're overrepresented in every major burden of disease category, particularly cardiovascular disease, cancers, diabetes, and chronic respiratory disease. And there's also a significant number of men's premature deaths that could be prevented through lifestyle changes. So men exhibit a high prevalence of health damaging behaviours such as physical activity. And one of these lifestyle changes that could make a difference to men's health and well-being is engagement in regular physical activity. So just to briefly recap, for those of you, most of us know what the latest recommendations for physical activity for health benefits for all people are. And so that's at least 150 minutes a week of moderate intensity aerobic activity, or 75 minutes per week of vigorous activity. And also there is at least 2 days a week of muscle strengthening activities. So just hold that in your mind as we go through the presentation. So if we look at global levels of physical activity, we see that more than a quarter of the world's adult population are insufficiently active. And so levels of inactivity are twice as high in high income countries, and there's been no improvement in global levels of physical activity since 2001. So that's kind of scary when 20 years ago we haven't really made a change. Okay, so for men's physical activity, we know across the lifespan that men have different motivations to be physically active. So, for example, younger men tend to focus on body image as a motivation for physical activity. Men around 33, 30-ish to 45 are focusing on being healthy to support their partner and children. And then as men move into the older categories, they're much more motivated to be physically active to maintain function and prevent chronic disease. But what is interesting is 1 in 4 men do not do enough physical activity to stay healthy. So meaning that they don't meet the recommended levels of physical activity for health benefits. But what about men living with disability? So it's extremely difficult, as I said earlier, to find recent data for physical activity levels for disabled adults, let alone have it separated by gender. But on the left-hand side of the slide, this is from Carroll and colleagues in 2014, and they published some data in 2000. The data was around 2010, but they published a study in 2014 that indicated the prevalence of physical activity. So that was the greater than 150 minutes per week of moderate intensity activity among US adults with mobility impairment. And they found that they were 21% active, meeting those levels compared with adults without impairment, who there's about 54% of adults without disability that were meeting the levels of physical activity. So the graph on the right side of the slide is also from the same study, and that talks about the prevalence of physical activity levels among disabled adults, and they were 18 to 64 years in the US, by whether or not the health professional recommended physical activity. And I thought that was an interesting concept to look at, because there's not a lot of difference between whether the health professional recommended activity or not. And I think what really strikes us on that chart is that there's a high percentage of disabled adults in the US either inactive, which is the very light blue bars, or insufficiently active for health benefits. So although we have no specific data for men living with disability, one could make a pretty good assumption that their physical activity levels are highly likely to follow a similar pattern. So we do know from literature that disabled adults experience many barriers to physical activity participation, and barriers can be either intrinsic, so factors that are personal to the individual, or extrinsic, which are imposed by the environment or society. And so there's a few examples I'll just share of barriers for stroke survivors' participation in physical activity. And these factors that I'll talk about shortly certainly mimic other adults with disability and their barriers to physical activity. So under the personal factors, it's things like barriers are physiological factors that are related to the stroke, pain, fatigue, weakness, those types of things. Psychological factors such as fear to exercise, low mood, low motivation, feeling unsafe to exercise. They could be embarrassed or have low confidence. Sitting within that personal factor category is also if we're talking about stroke survivors, is their knowledge and beliefs about physical activity. Often they don't know how to or where to exercise, and some also have beliefs that physical activity might worsen their health condition. And obviously there's also financial factors that play into the personal category. When we talk about the environment, barriers, definitely for stroke survivors, is lack of transport. And one of the really big ones, as you will be aware, is the inaccessibility of the built and natural environment. And then if we look at social, we're looking at lack of support available and negative attitudes from other people. Okay, so these barriers, however, don't sit in isolation. And to gain a better understanding on how these factors influence disabled men's participation in physical activity, using a different framework is actually really useful to think about this. And so this slide here illustrates the social ecological model, and to put it in context with the ICF, because I'm assuming that most people will know about the ICF. The ICF fits pretty much entirely into the individual bubble at the bottom, except for the environmental factors. And I used the social ecological model as a framework for my PhD, and I just felt that the environmental factors, which was what I was looking at, so I was looking at access to physical activity for men that had had a stroke, and it really was a much more user-friendly way that for the constructs to be organised. And I'm a pretty organised, structured person, and I like things to go in boxes, which is a bit bad, but I found that this model really helped. And so the underlying principle of the social ecological model suggests that an individual's attitudes and behaviours are shaped by the multiple environmental constructs, so the interpersonal, the organisational, community, and public policy. So I love the way that it's, shaped kind of like an onion, layers of an onion, that all of those levels will influence how an individual thinks and functions, and their knowledge and skills and things. And I think it's a really good model to help us understand about health and well-being and consider barriers to participation in physical activity. And as I said before, that all of these levels interrelate. So for example, at an interpersonal level, factors such as family members or friends, an individual's social networks, their cultural values, they're all influential on the person. At an organisational level, we're talking about maybe health professionals or exercise professionals' attitudes. Certainly policies of fitness facilities would fit into there as they pertain to people with disability. The community level talks to the built environment accessibility, and that is a massive factor in, that will influence whether someone with a disability will engage in physical activity in their community. And then at the public policy level, we're talking about local and national governmental laws and how they shape how a person can access health services. These laws or the legislation shapes how the community is designed, and then how we work within it as health professionals, and then how the individual accesses it. So you can see that all of these levels fit together really well. And spanning all of these environmental factor levels is one really big construct that I found is by far the biggest influence on a person's attitudes, beliefs, and behaviours. and that is societal attitudes or expectations, the stereotypes that society comes with or they generate, and societal norms. And so I've illustrated that by that yellow arrow, because this fits across all of these levels, like people's expectations. The policy is made by often by people that are not disabled, and and they're basing their policies on their expectations or their knowledge or lack of knowledge of how people with disability function. And this is going to be a really important factor in understanding men's health. So I'm just going to touch on masculinity. So society imposes a set of expectations about masculinity, and certainly understanding masculinity is really important for understanding how men engage in healthy behaviours. So what is masculinity? There's a couple of great documents which, when I send you my PowerPoint slides, I'll put these references in. So Vic Health in Australia have put this wonderful document together about masculinity, and they describe it as a set of practices and attitudes and behaviours that instruct what men should be and how they should act. Masculinity is learnt and expressed through observation and interactions with others in society. And this is a really important thing, that it varies between cultures and over time. It's important that we understand that masculinity is not a manifestation of an inner essence. It's socially constructed, and that it doesn't come from our biological makeup alone, and it's created within cultures. And masculinity means different things at different times to different people. So what this is suggesting is that a man's behaviour is largely shaped by the social environment. And I think that happens across all levels of the socio-ecological model. So where do these ideals come from? Well, they come from the social norms of the time. Okay, so they're unwritten rules about how to behave in society, or how men should behave in society. And I think we should remember that not all men conform to these expectations or are able to conform, but most at some point in their lives will feel the pressure to do so. So Hillman and colleagues in 2017 explored the social pressures and individual attitudes to what it means to be a young man. And they looked at that in the US, the UK, and Mexico. And they created this concept called the man box. And so the man box explains widely reinforced norms where men feel pressured or encouraged to act in these ways at some point in time. So there are 7 pillars that form the contents of the man box, and these reflect societal expectations or messages of what a real man should believe, or how a real man should behave. So the first thing, that one of the pillars is self-sufficiency and emotional control. And that's often illustrated by men who feel they shouldn't rely on others. They talk about their feelings, or they don't talk about their feelings, and they don't seek help for their health. So the second pillar is acting tough and risk-taking. And so men feel that they must maintain this outward appearance of toughness and strength, even when experiencing more vulnerable emotions. And this is this notion of upholding invincibility. The third pillar is about physical attractiveness, and this idea that real men dress well and look good and achieve this without seeming to try very hard. Men who prioritize physical attractiveness engage in behaviors that they believe makes them appear more desirable to women and to seem cool in their peer group. Pillar 4 is about rigid masculine gender roles, and there's this perception that certain activities and duties are either masculine or feminine. For example, men feel that they are primarily the financial provider, and healthcare is a female task. Interesting, I went out socially a few years back and was talking about my PhD with someone, and it was a guy, probably around my age, and he and I said to him, "What does health mean to you?" And he goes, "Oh, health is for chicks." So it was really interesting. And then we asked his son, and I asked him, the son, the same question, who was probably in his late teens, and he said, "Well, health is for everyone." So we can see just with that there's lots of different ways that men perceive themselves, and in different age groups as well. So carrying on about these pillars. So the 5th one is about superiority amongst males, and there's a socially constructed hierarchy of male identity and belief that men must be superior. And so this includes marginalization or idolization of men based on specific behaviors, which is seen more or less masculine. So that would be this idea of heterosexuality versus homosexuality. And so men who don't engage in masculine behaviours or are unable to, I think that's important to think about with men with disability, are seen as less masculine. Pillar 6 is about hypersexuality and the emphasis that men should have as many sexual partners as he can, and he's always ready for this next sexual conquest, and this idea that only women say no to sex. And the last pillar is about aggression and control, and there's this emphasis on the need for real men to use physical violence when necessary, and also to hold control over household decisions maybe and women's movements. So we can see across generations that these ideas of the man box would come in as well. So disabled men who identify with all or some of the pillars in the man box can feel that their masculine identity is threatened. And so drawing on some very limited literature from male stroke survivors, the male stroke survivors in this literature felt an overwhelming sense of disrupted embodiment and loss of their masculine identity. And they mourned the loss of their physical strength. They became frustrated by their reduced ability to engage in their pre-stroke activities, especially around the breadwinner role. They expressed their feelings of guilt about being a burden within the family unit because they could no longer provide financial, physical, or emotional support. And this caused many male stroke survivors to feel inferior across all aspects of their lives. And that led them often to become socially withdrawn. So what does all this mean for men's health behaviour? So how men choose to construct their masculinity will affect their health beliefs and behaviours. So, for example, men who exemplify health seeking and health care often serve as great role models for younger boys and other men. And so there's this idea, of course, that healthier men contribute to healthier families, healthier communities, and healthier societies. So in contrast to those men who adopt the pillars in the man box, they're more likely to reject health-promoting behaviours and associate seeking help and caring about their health with feminine behaviours of weakness and vulnerability. So I just want to go back to the comment I made earlier that 1 in 4 men meet the recommended levels of physical activity, and how men with disability are much less likely to be physically active because of the barriers that we've talked about earlier. So what I found really interesting is this paradox between the idea that some men want to appear physically strong and independent. So I assumed that engaging in physical activity would be a great way for men to enhance these factors, so like being strong and independent, and therefore that should positively influence their masculine identity. So, and even better for men living with disability, if they had these thoughts about being strong and independent and what have you, I thought that community fitness facilities would be perfect places for them to be physically active. And I thought in terms of men with disability, men with stroke, that fitness facilities could be this one-stop shop where they could engage in the recommended strengthening and balance and flexibility and cardiovascular fitness. And they could do that in an environment that was inclusive, safe, and supportive. So with this thought and the fact that we know that men with and without disability understand the benefits of physical activity, and they understand these benefits in terms of preventing chronic disease, reducing obesity, and maintaining general health and well-being. So they know this already, yet very few men with disability participate in the recommended levels of physical activity for health benefits, and let alone go to a fitness facility. So why is that? And so this is what I explored in my PhD, which looked at access to physical activity for men following stroke. And I had a particular focus on fitness facility accessibility. So, and we find with no surprise that there are multiple factors which influence whether a male stroke survivor will access physical activity at fitness facilities. And so, as I said earlier, I used the socio-ecological model to explore this in a little bit more depth. And it was really helpful to illustrate this idea. And I'm just trying to get my cursor down to the bottom here. I'm going to start backwards, okay? So I'm going to start right down at the social policy level and explain how this works its way up to influence, to some degree, how male stroke survivors face barriers to participation at fitness facilities. So local and central government, actually the legislation for accessibility is minimal standards. So there are standards available that are not mandatory. So when a fitness facility or any building is built, there's the minimal standards in the building code that buildings must comply to. And then there's these accessibility standards that are that builders can choose to enhance their building for accessibility. And so clearly, if the legislation is minimal standards, that's going to affect the building professionals and how they actually build a building and construct it. And so clearly that's going to move along here, and we're going to get these fitness facilities that perhaps are inaccessible. And then that leads us to the organisation not thinking about having people with disability accessing their facility, their programs, their mission statements and what have you aren't inclusive. And then we can move forward to the fitness instructors here. And so they don't have a lot of knowledge about working with people with stroke or with disability, and clearly that's going to affect our male stroke survivors wanting to exercise there. And so also we've got support persons and their beliefs, whether the primary carer believes that physical activity is going to be beneficial, that will influence a male stroke survivor. And then to the left, we've got the health system. That's problematic because there's not a lot of resources out there. And then we've got health professionals' attitudes towards physical activity and how they educate male stroke survivors. So all of these things can be barriers. Sometimes they can be facilitators as well. So this next slide is pretty busy. And we're not going to go into it in depth, but just to expand from that previous slide. So what I'm showing here is a perspective from me as a physiotherapist, and the multiple collaborations and associated strategies that I really would need to think about when I'm thinking about physical activity for male stroke survivors, if I'm wanting them to access an inclusive place in the community, such as a fitness centre. Okay, and so it really blew my mind. The PhD was amazing for this, because originally I'd probably just think up here of the strategies that I'm using with the male stroke survivors. So fostering hope and trying to re-establish identity, doing collaborative goal setting, involving the partner, making sure that, you know, our education is good. But I never really considered all of the stuff that I could kind of do to facilitate or advocate for stroke survivors' physical activity out in the community. It never crossed my mind that we should be thinking about policy to advocate for change in the building legislation. That is one of the biggest problems. Oh, hang on, I've gone too far, sorry. And so it really, the social ecological model just really struck for me that I've got to think far beyond just the patient in front of me and across all of these levels. So I'm going to talk about some strategies to enhance men's physical activity, and so a lot of this has come from the literature, and the slides refer to men in general because there's very, very little literature for promoting physical activity for disabled men. So there is literature about physical activity for people with disabilities, but not specifically for men. But I think the principles of what I'm going to talk to would still fit with men with disability. And just to bear in mind that I'm not presenting the strategies in each level of the socio-ecological model, because they often span many levels, but just to have that in the back of your mind. So in terms of what's important for men's physical activity, is to have a gender-based approach, and recognising that men have quite different health needs from women, and that we need to address men's health from a strength-based approach, okay, where men are empowered to build health capacity. So rather than us saying, oh, you're a typical bloke and you probably don't, you know, you want to look good, and you know, you want to be strong and powerful, and attending to those negative or the deficits of men, is to turn that around and think about how we can empower them to build health and enable men to define what health means to them, and try and avoid this negativity about masculinity. And that we need to remember that men in good health, as I said before, who exemplify these health seeking and healthcare, they're really, really good role models for other men. And I think if we could hold on to that, maybe in our practice, if we find someone like that, is to embrace them and see if we can use them to help us with other men. Okay, physical activity must be meaningful to men's aspirations, their motivations, and their goals. And Ryan, way back in 1997, had these wonderful reasons for why people could be physically active. And I think men would really, really identify with these from reading the literature. They all say that the activity has to be enjoyable. They are actually doing the exercise for their appearance. They're doing it for social connection, for fitness and health reasons, and they really love the competence of achieving an activity, and they love the challenge. So I think way back then there was these wonderful principles, and if we could hold on to those while we're prescribing our exercise, that would be amazing. So we also know that men really prefer a gender-sensitive approach to physical activity. And so things like really pragmatic things, like they're really most men are really practical. And so they want their physical activity to be incorporated with their everyday world. So like often walking for travel or biking for travel, and acknowledging that household activities like mowing the lawns and washing the windows and all of that are still physical activities. They quite like men's only groups to be physically active in, because that promotes this idea of the brotherhood and social connection. And although they like social connection, they actually participate because of the activity. They would prioritize the activity over the social connection, but they do like both. But there's also men, obviously like everyone else, that also like to exercise or be physically active on their own. They really like friendly competition and banter, that as long as it's friendly. And that goals are super important for men, as it gives them something to work towards, which helps them with self-competition, and they like to self-monitor how they're going. And involving family members is really helpful, especially if the men have children that they can do their physical activity with, or grandchildren, because that really promotes this positive role modeling as well. The other thing that's really important to consider is where men are likely to feel comfortable engaging in physical activity. And so thinking about the environment that fosters this openness, acceptance, support, and alternatives of physical activity that are meaningful to men. So sports organisations are really good because they're friendly, relaxed, non-directive in terms of the program delivery. They foster banter, often to discuss serious topics. And the men like them because they're often of a similar age, and they promote friendly competition. And they might, the activities that the reason why they're going to a sports club is because they probably engaged with that sport previously. And so that's quite a nice way to get them back into physical activity. Community-based, obviously there's men's shed, that's excellent, and they're with like-minded men, so that's often really helpful. Something that I hadn't considered actually was work-based environment. So they like that because there's a minimal time commitment, it's embedded into their daily routine, it's practical, it's a pragmatic way to exercise, it's a familiar environment, and there's often collective engagement there. And then they also like IT interventions or apps on their phone, or if they've got a smart watch, because that promotes self-challenge, competition. It's often really goal-directed, and really good if men are reluctant to do face-to-face interventions. So I also looked into strategies for Maori men, and there's a couple of there's literally hardly anything. Isaac Warbrick up at AUT and his colleagues have investigated physical activity for Maori men, and they've provided some really useful strategies. And it's important to think about Maori men tend to identify with holistic aspects of health, and they place this equal emphasis, as we know, from the model of Māori health to whare tapawhā, and so they're really wanting this balanced approach, and they consider spiritual, mental, social, and physical aspects of health equally. And so factors that foster success for Māori men participating in physical activity are having support, and so I tried to illustrate this here, where, and this is the same for other men with disability as well, is that the thing that's the key to success is having support and ongoing support. and that is really true for Maori men. And physical activity with the bros. So that whole idea of exercising with other men, it promotes this fellowship and motivation, competition. And for Maori men in particular, it's about accountability. When they're exercising together with other Maori men, they don't want to let their mates down, so they go back. And again, that having fun and the banter increases their motivation. And really highlighted for Maori men and physical activity is they're doing it to be role models for their tamariki. And they really like programs that emphasize the collectiveness of physical activity. Okay, so just touching on health messages, physical activity health messages for all men. They need to be clear, simple, and prescriptive, avoiding words with direct health or feminine connotations. Emphasize the team aspect for men who enjoy sport, and to have humorous language with them, and information on frequency, intensity, and duration. So what I can share with you, which is quite exciting and hot off the press, is some early findings about physical activity health messaging for men living with Parkinson's disease, and this is from a New Zealand context. So I've worked with a summer student, a physiotherapy summer student, Karis De Silva, and she was supervised by Professor David Baxter and myself. And so she's looked at reframing physical activity health messages to be meaningful to men living with Parkinson's disease. And so what we were thinking here was that the use of imagery for health communication is a really powerful messenger to influence men's motivations to participate in physical activity. However, successful delivery requires that imagery has got to be meaningful and it's got to be culturally relevant. And so this research explored the views of New Zealand men living with Parkinson's disease about existing imagery for physical activity health messages and how that they might adapt them to be meaningful, valuable, and inspirational for them who are living with Parkinson's disease. And so what we've come up with so far is that the participants felt that the imagery needed to focus on what motivated them to be physically active. So that was their the effects on their physical health and well-being, the effects on their mental well-being, and that that illustrated social participation as well. And what we also found out that that health professionals aren't very good at giving explicit information or depthful information about physical activity. We say that they should do it, but we don't actually tell them how or where. And these men with Parkinson's disease wanted the messages to be positive, inclusive, but minimalist, but they also had to be credible. Now we're just moving on. Karis is doing the honours program in physiotherapy, and she's looking the same study with male stroke survivors, and this is really interesting. And there's quite the contrast between what type of messages male stroke survivors want. And so some of them have said they want positive messages, but then others have said that they're looking for kind of a bit threatening messages, like or the words that they used were "get off your ass" and "get moving," and or even to the. I was kind of horrified, but one of the men said, "Hey, fatty, you've got to get off your ass and get moving." And I'm thinking, golly, I'm not sure how I'm going to represent that on a poster, but you know, like, it just highlights that there's you know, people with different conditions are looking for different health messages, or they're meaningful in a different way. And so following on from Karis's study, I'm alongside Prof. Baxter and Elaine Hargraves from Physical Education at the University of Otago, are looking at how middle-aged and older men living with physical disability illustrate how they're physically active using photography, with the idea that maybe imagery that illustrates men engaging in a healthy lifestyle may be influential to motivating other men who aren't active. And this whole idea of having imagery of like-minded people, because when you go to the images now of people with disability exercising, you look at the Nike ads and it's all Paralympians, and my thought, I'm not sure that's relatable to Bob next door who's had a stroke, and helping him access physical activity. So I'm shamelessly recruiting here. So if anybody knows of anyone with a physical disability or other disability as well, who might be interested in participating, please just get in touch with me, because it's a very cool project. I think some people are put off by the fact that they might have to photograph themselves and the frontal perspective, but there's ways around that, and that doesn't have to be the case. So just before I finish, I think it's important that we just come back to the policy level for men's health, because it's all well and good educating about men's health and putting programs in place, but I think the word on the street is that this is insufficient for success, and to strengthen men's health, it needs to really be supported by policy at a national and global level, and also allowing for funding and sustainability for programs, as long as they're supported for men's health. And I think we're slowly starting to see a change for men's health on the global scene, and this document here, From Margins to the Mainstream, is a great document about advocating for inclusion of men's health in policy. And you might be interested to know that only 3 countries have developed a national men's health policy framework. That is Australia, Brazil, and Ireland. So New Zealand has no strategy for policy to address men's health. And so I'd be really interested to hear your thoughts or comments on how we might be able to enhance men's health in New Zealand, or men's physical activity. Yeah, so I think we're just at the start, but I'd be interested to hear your thoughts. So I'll just stop sharing. Yeah.
Thank you, Ellie. That is really fascinating, and there was lots to take in and lots to contemplate. I particularly liked the image of your reflections as a physiotherapist and the various roles that you could have more generally when considered against, advocacy, changing attitudes, informing, and training, gym instructors, etc., and just I guess the broadness of our role, and not being sort of limited to this sort of just who's there in front of us. And so I found that really challenging, so thank you. If anyone has got a question for Ellie, this is a really good time to unmute yourself, and if possible also show your picture and ask Ellie any questions that you have. Or you could alternatively put them into the chat, and we'll keep an eye on that as well.
I have a comment, if that's all right. Thank you for your presentation, Ali. I thought that was great, and I really enjoyed the broadening of the scope away from the individual, and I think that's wonderful to see among clinicians. And my background is in public health, and I taught public health, and I think one of the revelations year on year for me in talking to students who had a clinical background was the scales fell from their eyes when they understood that broader environmental and public policy and societal context. And I just want to congratulate you on your work, and just say keep doing it, and keep in touch with public health colleagues too, who will be really interested in what you're doing.
Thank you so much, Pauline. I've often felt on a little bit of a limb, having done this PhD as a physiotherapist. so outside the box of where often, not all physios, but a lot of the people I was doing my PhD alongside are still sitting at that individual level, and there's nothing wrong with that because we need evidence there as well. But I think they thought I was slightly strange looking way down this road. And yeah, as I said earlier before a lot of people jumped on, what's happened really excitingly is that we've managed to get one of the Christchurch City Councillors, Aaron Kewen, who is the disability lead for the council, to come and have a look at a gym environment. He basically said, what do you need? And I thought, wow, that is so exciting. We're slowly moving forward. And I think one of the biggest things I found that I concluded in the PhD is that it's really, really hard to facilitate change at those outer levels, the organisational, community and policy. It's so hard to make those changes, and we need to have a groundswell of people. It needs to be research. It needs to be for the end user, the person to whom it matters as well, and trying to get this group of people together to make it go forward. Man, that's challenging. So yeah.
Public health is always for the long haul, you know. It
Yeah.
really is. So
Yeah.
good luck and keep going.
Thank you.
Jean, I see you've
Ellie,
unmuted
it's,
yourself.
Yeah, kia ora, Ellie. It's Jean speaking. Welcome to the out of the box space. There are some of us who like that, to occupy it a bit.
Jean, your sound is quite quiet.
Yeah, sorry. I had my thing up out of the way. Kia ora, Ellie. I was going to say just welcome to the out of the box space. I utterly agree with Pauline about the value of the work you're doing here, and just congratulate you on it. It's fabulous stuff. The thing that occurred to me as I was listening to you, and I'd be interested in your thoughts on this, is that of course I occupy an out of the box space about the health of women, and you're occupying it perhaps a little more from the perspective of men. And I would say that the system typically doesn't suit women very well either, particularly our Māori wahine doesn't suit them at all well. And one of the things I'm wondering about is, who does the system suit? Is it that it doesn't suit most men and it actually doesn't suit many women? And actually the system is set up for white, well-educated, highly motivated, well-informed people, and pretty much that is not so, you know, it's not gender specific in that sense. It suits a particular group of people, and pretty much everyone outside that small group of people aren't suited by the current system at all. And so part of our issue is thinking, as you're doing in the socio-ecological way, which is fantastic, to think about who does the system suit. And actually mostly doesn't it not suit many.
Yeah, I absolutely agree. And when they talk about in the literature around men's health, is that we shouldn't be talking about men's health versus women's health. That's one thing. That we should be emphasizing the strengths of everyone's health. That and what, I don't know why we just can't, because not everyone identifies as a man or a woman. So I mean, wouldn't that just be groundbreaking if we could have this idea that everybody was just a human and they came with limitations? I mean, we've all got limitations. I've got limitations that I'm kind of blind, and probably some other ones as well, which Rochelle might have kept in her under her hat. And why can't we just? Yeah, I mean, I agree. I don't know how to do it, but we've got to start somewhere. I guess if we start with this idea of men's health, but not at the expense of women's health, and that we try and look much more widely culturally. I think that's really important, in trying to look at it from a Pacifica, from a Māori perspective, from an Asian perspective, from a gender perspective. Man, I think that would be amazing. So there's lots of work to do, you guys.
Just to further that, I wonder whether the system actually suits for the healthcare professionals that provide it rather than for anyone who's receiving it. And actually, if we started to actually listen to the users of services and plan services around their individual and bespoke needs, maybe we'd be starting on the right track. There's a question from Tara here on the chat. Keen to understand more how men feel about exercise as part of self-management of their disability or health condition. Has this come up?
Oh, actually, not that I've found. I think that is definitely on the cards for investigating. I think I can tell you this is my own brain though, not probably from literature, that in terms of self-management for male stroke survivors, and I can speak for them because I worked with them in my PhD, is that it seems to me that there's this continuum of once you have your stroke, which is a life-changing event, that you go through this almost like a grief process, but a continuum of, of trying to get to acceptance and building resilience. And I think not everyone gets to that acceptance phase. And I wonder, this is only my own brain thinking, I wonder how easy it is to self-manage if you aren't at that acceptance or resilient phase. I don't know. I don't know if that answers your question, Tara, but
thanks, Sally. I think probably I'm coming from a different perspective with people with long-term conditions, but that's a message that we're trying to really keep emphasizing, that it's not just physical activity for image or for general health, but actually as part of their self-management of their condition. And I also just wanted to add a comment around what you were saying before around the gym environments and some of the issues there. And having worked in gyms many years ago, I think we're just starting to kind of find that shift between gyms and fitness as being part of an image thing, weight management and how you look, and now more on health management. And I think that's where things will really start to tip the balance when we realize it's actually just a health management facility and not an image management facility.
Yeah, I totally agree. I think, and that, to be fair, that's where the my health messaging study has arisen from. Was from we went to visit some gyms with a bunch of blokes, and they were looking around the walls, and obviously the imagery is, skinny people in lycra with big muscles, and tongue in cheek, one guy said to the lady that was taking us around, "Wow, oh, you haven't got any people that look like me on the wall. And I'd be happy to be your model." And she was kind of like, "Oh my goodness, it's all done from head office." And I think that's one of the biggest problems, is that we're not catering for like everyday men doing everyday things. Like, that's kind of where I'm coming from. Like, it's no point looking at a Paralympian if you're if you don't relate to that. Some people might aspire to that, and that's cool. So you have to have imagery and messaging that spans a whole lot of different things.
And the other one thing I was going to add as well, I think you're totally on it there, is the health and fitness professionals, the industry has, especially for like personal trainers, apparently a lifespan in New Zealand of about 2 years from qualification. So people go into that profession but don't stay in it. So it's a really young professional population who quite often we're sending people to without a lot of life experience to relate to some of the things we're asking them to relate to.
Yep, I agree.
I am going to pull it to a close now. I'm sure there are lots of more questions, and we probably all know people who would love to be part of your study. We just have to share the good news with them. So you're going to send us your PowerPoint, is that right? And we'll be able to disseminate that. And yep. If you also send an invitation sheet, will that be part of the materials you send through? That would be fantastic. And I'm sure Ali would be very, very happy to chat to anyone who's got an interest in this space or would love to sort of explore a bit more how they could be involved. I know us researchers are always looking for ways we can connect with what's happening, you know, clinically as well. And so if you've got a good idea, come to us, and we love to help support you with that work as well. Ellie, I want to thank you so much for your presentation, but also more for who you are and the way that you've really engaged with this really complex and difficult question, and you're trying to make a real significant difference to men who experience disability. So thank you. I know your PhD was sustained effort, walking in the same direction, and so go you, and I'm hoping that you're now getting lots more time to do your Highland dancing.
No, one exam to go Saturday.
Is it?
And it's over and out, and I'm that excited. My daughter does Highland dancing. She's done Highland dancing since she was about 3.5, and she's done all her exams, and we've got to the last one, which is an hour, 15 minutes solid dancing, full on, plus oral theory, which is like 20 pages of stuff, which Muggins here has been. I think I could sit the exam. So I'm excited for Saturday. But thank you all. Thank you so much for inviting me. It was wonderful. Cool.
And we'll look forward to seeing you all again. Lovely to see you all.
Cool.
Thank you.